Students, now let's talk about the distribution. What is distribution? We have discussed that from our basis of general pharmac, the movement of drug molecules from the blood to the tissues. Movement of drug molecules from blood to the tissues. From this, we can easily understand that whenever a drug molecule is moving out of the blood vessel, what do you expect the plasma concentration is going to be? Plasma concentration is going to be decreased further because from the plasma it is moving out. This is, I'm just repeating what we have already discussed from a general basic concepts of GP itself, that is plasma concentration versus time plot. Consider here is where your plasma concentration and we have time. Whenever you administer a drug via per oral route, when you administer a drug via per oral route, what will happen? From the intestines, the drug is slowly moving into the blood vessel, so the plasma concentration will be rising. It will reach to a peak. After reaching its peak, the plasma concentration is going to be slowly falling down. This increase in the graph, or to say this rise in the graph, is due to absorption, whereas the decrease in the graph, the plasma concentration is falling down. That will be explained as distribution, metabolism, and excretion. So the reason why the plasma concentration is rising is due to absorption. The reason why the plasma concentration is falling down is due to distribution, metabolism, and excretion. Consider you administer the same drug via, instead of per oral route, you administer it via parenteral route, intravenous route. You take up 100 milligram in a syringe and you administer that drug directly into the plasma, which means what? Initially the plasma concentration is going to be 100 milligrams. So the graph will start at this point and slowly the concentration is going to be falling down. Here the initial few decrease, that is what due to distribution. The first part of how the plasma concentration is getting decreased, that is what explained as distribution, guys. Again, we have two different complexes of a single compartment and multi-compartment models. We'll discuss that later. So here, as per distribution is concerned, you have to understand that the drug from the plasma is moving out of it. Let's look into the second factor. Let's look into, consider here is where your blood vessel is, and we have an individual cell. It might be a tissue. Inside the tissue is where your target protein is. Target protein, I'm going to be writing it up as a T. T stands for target protein. Whereas the same protein which are present inside the plasma, we're going to be drawing it as P, which is called as plasma protein. So we have target protein or the tissue protein, and we have protein which are there in the plasma called as plasma protein. Here there is an equilibrium, ideas. Whenever you administer a drug molecule, the drug molecule from the absorptive side or from the site of administration has gained entry into the blood. Now the drug molecule which is there inside the blood will be there at equilibrium. What exactly is that equilibrium? Between a free molecule and a bound form. A drug molecule can either be free or a drug molecule can be bound with the plasma protein. What is the importance in knowing about this? This equilibrium will be constantly maintained. If there is any decrease in the free form, drug from the bound will go back to the free form. If there is a decrease in the bound form, drug from the free will be going and binding with the plasma to maintain the equilibrium. That's how the equilibrium is going to get maintained. And why is this particular equilibrium very much important in pharmacokinetics? Please note, bound drugs will not be able to cross the blood vessel wall or blood vessel membrane, whereas only the free drugs will tend to cross the membrane, gain entry inside the cell, bind with the target tissue and produce the pharmacological response. So simply put, which drug will be produced, which drug is responsible for the pharmacological responses, free drug or the bound form? Fantastic. Free drug will be producing the pharmacological responses. Bound drug will not be producing any pharmacological response, but this bound drug is responsible for maintaining the equilibrium between the free form and the bound form. For example, as I've told, this drug molecule, this drug molecule, as we have drawn, is crossing the barrier, gaining entry and producing the mechanism of action, following which this drug is going to get metabolized and excreted out from the body. If these free form levels are getting decreased, what do you expect? How the level is going to be maintained back? This bound form is going to be producing or maintaining the equilibrium, it will start releasing the bound form. It will start releasing the drug from the plasma, thereby maintaining the equilibrium. This bound form will be converted to free form, and that free form again will be producing the mechanism of action. So simply put, we have two different complexes. One is free form of a drug, which is binding with the plasma protein, thereby it forms an equilibrium with the bound form. Out of this, which is producing the mechanism of action, my dears? Fantastic. Free drug is producing the mechanism of action. Bound form is not responsible for producing the mechanism of action. That's why we call the free form as the active form, whereas the bound form is called as the inactive form. Free form will be called as the active form, bound form will be called as the inactive form. Two different complexes as per plasma protein is concerned. Now let's look into those plasma proteins. What exactly happens whenever a drug is binding with the plasma proteins? What do you expect the effects is going to be? Is the effect seen in the patient or the effects not seen in the patient? Effects will not be seen. That's the reason why we call these plasma proteins as site of loss. Site of loss, because when you administer a particular drug, we'll be discussing more about that in pharmacodynamics, guys. We have a basic formula of any drug if at all its mechanism of action is concerned. A drug molecule will be binding with the protein, thereby increases or decreases the synthesis of one more protein. I'll repeat that. A drug molecule will bind with the protein, thereby increases or decreases the synthesis of one more protein. That's the basic formula of any drug, from the autonomic nervous system till the last anti-cancer drug or the newer anti-cancer drug. Any drug, this is how the drug is going to be producing its mechanism. Here also, as we can see in this explanation, the drug is binding with the protein. It should produce the response, but it is not happening. It is producing the opposite response. For example, here the drug molecule is binding with the protein, but unfortunately it is not producing any response. Instead, the drug is converted to an inactive component. That's the reason why we used to call it them as site of loss. The other name is, these are also called as drug acceptors. These are also called as drug acceptors. One more name is there. We'll discuss that later, buddy. Because based on the pharmacodynamic features, we have written one more name for this plasma protein. We'll discuss that later. So as we can see, if we want to see the responses of a drug, the drug should be in which form? Should be there in free form or in the bound form? Fantastic, it should be there in the free form. If it is bound with the plasma proteins, the effect is going to be decreased further. Now, let's look into what are the classical features of a drug if we call them as a high plasma protein bound form. If a drug is having a high plasma protein bound form, what are its classical features? It has got three important features. Number one, this drug will be having more drug interaction. This drug will be having more drug interaction, more duration of action, and less distribution. We'll discuss that one by one. Let's first talk about a drug with high plasma protein binding. What about this increased drug interaction? Consider here is where blood vessel is. You have administered a drug for a patient, and this drug molecule is getting distributed to the nearby tissues. Now consider here I'm going to be explaining about a drug which is warfarin. Consider I'm administering warfarin for the patient. We know that warfarin is an anticoagulant drug. Warfarin will gain entry inside the blood. We have warfarin which is accumulated inside the blood. Warfarin is a highly plasma protein bound form. Majority, around 90 to 99%, will be bound with the plasma proteins. So what happens? Warfarin is binding with the plasma proteins. The drug which is going to be free, for example, consider here in this example, I have drawn one molecule of warfarin which is bound with the plasma protein, one molecule of warfarin which is free. This free warfarin is the one which can cross the membrane and gain entry into the cell, into the target cell, to produce its own responses. What's the mechanism of action of warfarin? Vitamin K epoxide reductase enzyme inhibition. Don't worry, even if you don't know, we have discussed that in detail in blood pharmacology, buddy. Inside the target cell or inside the hepatocytes, we have this VKOR enzyme, vitamin K epoxide reductase enzyme. The free molecule of warfarin which is there, which is accumulated, which this will be moving inside the cell, thereby binds and inhibits the vitamin K epoxide reductase enzyme, and it is used as an anticoagulant drug. This is an anticoagulant. Usually what we do when you administer an anticoagulant, we add an antiplatelet drug. Now for this same patient, I'm going to be administering aspirin. Aspirin is an antiplatelet drug. This aspirin also is going to be gaining entry into the blood vessel. We have aspirin gaining entry. But understand that this aspirin has got different mechanisms, cyclooxygenase enzyme inhibition. But what is the relationship with this? Aspirin also has got high affinity with the plasma proteins, more than what warfarin is going to be having. So what happens? Aspirin will come and bind with the plasma proteins. How it is going to be binding up with? It displaces the bound warfarin from it. When this bound warfarin, which has already been there, has been displaced out from that, what will happen, buddy? The free concentration of warfarin is going to be increased. When the free concentration of warfarin increase, as we can see here, two molecules of warfarin will gain entry inside the cell and start producing the responses. Thereby, the patients will land up in warfarin toxicity. What is warfarin toxicity? Patients might land up in bleeding, as simple as that. So simply put, whenever a patient is administered warfarin along with aspirin, when a patient is administered warfarin along with aspirin, their patients are more prone to land up in bleeding. And why is there? Not because of additive responses, it is because of a drug interaction, which we used to call as displacement reaction. A beautiful terminology, buddy. Displacement reaction means aspirin will displace warfarin from the plasma protein bound site, thereby converting a bound inactive form of warfarin to an active form of warfarin, which is producing the mechanism of action. Thereby, the patients might land up in bleeding. So can't we see this warfarin aspirin interaction with any other drugs? Practically speaking, any of the drugs should be producing the responses. No, it will not be seen, guys. Why? Because we have something common between warfarin and aspirin. Both of these drugs are acidic drugs. Warfarin sodium, I hope you remember that the drug name is ending with sodium. It is forming a salt with a cation. It is also an acidic drug. Aspirin, the other name is acetyl salicylic acid. That is also an acidic drug. And why an acidic drug will always be displaced only by an acidic drug? A basic drug will always be displaced only by a basic drug. It's simply based on the plasma proteins in which those molecules are binding. An acidic drug will bind with the plasma protein, which is albumin. An acidic drug will bind with albumin, whereas basic drugs will bind with alpha-1 acid glycoprotein. Alpha-1 acid glycoprotein. All the acidic drugs will be binding with albumin, whereas basic drugs will be binding with alpha-1 acid glycoprotein. Well, that's the reason why we say an acidic drug will be displaced by one more acidic drugs. We can write it up over here. An acidic drug will be displaced by one more acidic drug, whereas a basic drug will be displaced by one more basic drug. The vice versa will never happen by us. The vice versa will never happen. An acidic drug will never displace a basic drug, and a basic drug will never displace an acidic drug. This is a formula. Why this formula is very much necessary? For example, you look into, you will land up in your question. In that question, you will land up in a random drug name. You don't even know what that drug is. And the question is, which of the following tend to displace this particular drug? You just need to find out what exactly is that drug, whether it is an acidic drug or a basic drug. If you know that is an acidic drug, you just have to find out one of the acidic drug in the options. Or if it is a basic drug, you have to find out one of the basic drug in the options. That's how we have to come up with the answer, as simple as that. So till now we have discussed about what exactly happens to the plasma concentration whenever distribution is happening. Then we came up with what exactly is plasma protein binding and what are the characteristic features of a drug with a high plasma protein binding. The first one, I was talking about displacement reaction, which is responsible for drug interaction. The second one is duration of action. Any drug, if it is having a high plasma protein binding, will be having a more duration of action. How it is actually been positive? Consider here is where your glomerulus is, and we have the proximal convoluted tubule, descending limb of Henle slope. I'm not drawing the full nephros because that's not necessary right now. So here is where the afferent arteriole is situated. For our understanding, I am drawing it separately. Afferent arteriole is there. Again, we have the drug molecule. Drug molecule can be either free or the drug molecule can be bound with the plasma protein. If it is acidic, binds with albumin. Basic, binds with alpha-1 acid glycoprotein. Good. Now here, this glomerular membrane, this filtration which is happening via the glomerular membrane is primarily dependent on the size of the molecule. If the size of the molecule is very much smaller, it will easily pass through the membrane. If it is bigger, it cannot pass through the membrane. As simple as that. And why is it? Because we all know from physiology itself, glomerular membrane is just like a sieve, a small gap which is there. If a drug molecule is smaller, it can easily pass through the membrane. If the drug molecule is bigger, it cannot pass through the membrane. If a drug molecule is smaller, which means drug molecule is free in nature, it can easily cross the membrane and gain entry into the cells, into the urine. Whereas if the drug molecule is bound, it cannot even cross the membrane. That's the reason why we say drug with high plasma protein binding tend to have a longer duration of action. And why is that? If you want to put it up in words, because of decreased filtration. Because of decreased filtration from glomerulus. Because of this, the duration of action is going to be prolonged further. Good. We have till now classified two important points, my dears. Drug with high plasma protein binding tend to have more duration of action. Why? Because of displacement reaction. The second one is more duration of action. Why? Because of less filtration. And number three, the third important point is less distribution. This, I think there is no need to explain, my dears. Why? Because distribution is movement of drug from the blood to the tissues. So if a drug is highly plasma protein bound, it will remain inside the blood. So the distribution is going to be lesser, as simple as that. With this, we complete the classical features of drug if it is having a high plasma protein binding. Okay. Now, moving on to the next important concept within distribution, which is volume of distribution. Which is volume of distribution. What exactly is this Vd, volume of distribution? Consider, guys, you take up a beaker. And you just pour around 100 ml of water in it. You take up a coloring substance, a very much highly concentrated coloring substance, and you put it up as drops, right? 1-2 drops, you just put it up inside. This coloring substance, which is going to be blue for our example, this coloring substance will be discoloring, for example, around 30 ml of blood or 30 ml of fluid. If I take a stirrer and I just stir it, here we can see the whole 100 ml will be getting discolored. But if I don't stir it, as we can see, just pour a drop, slowly it will be discoloring only around 30 ml of fluid. The remaining 70 ml will not be discolored. This 30 ml of fluid into which the coloring substance is getting distributed, that's what we call as volume of distribution. If you just compare it with the human body, you take up the whole fluid which is present inside the human body, put it up inside a beaker, and you just put the active drug, the test drug, and see to how much ml of fluid the drug is getting distributed. Study of that is what we call as volume of distribution. But unfortunately, we cannot take the whole water out from the body, right? So what we do, you administer the drug to the patient, and we calculate to how much ml of blood or how much ml of fluid the drug is getting distributed. We have lots of different fluids inside the body, guys. We have the blood plasma, which is a fluid. We have the intracellular, extracellular, synovial, pleural fluid, cerebrospinal fluid, aqueous humor, vitreous humor. Lots of different fluids are there inside the body. So how much ml of fluid the drug is getting distributed. Study of that is called as volume of distribution. If you put it up as a definition, volume of distribution is volume of body fluid into which drug gets distributed. Volume of body fluid into which drug gets distributed. This is what called as volume of distribution. We cannot actually calculate how much ml of fluid the drug is getting distributed. That's why we don't call it as Vd. Instead, we call it as apparent volume of distribution. What exactly is the clinical importance of knowing whether a drug is having a high Vd or low Vd? Understand this. If a drug is having a high volume of distribution, if a drug is having high volume of distribution, it means more of the drug is getting distributed. I hope you're all there with me. High plasma protein binding means more of the drug will be situated inside the plasma. High volume of distribution means more of the drug is getting distributed, more of the drug is there inside the tissues, which means these drugs will be having more tissue protein binding. These drugs will be having more tissue protein binding, whereas less plasma protein binding. More tissue protein binding and less plasma protein binding. Very important step, guys. We have seen multiple questions asked from this one liner itself. So please understand that if a drug is having a high plasma protein binding, more of the drug will remain inside the plasma. High volume of distribution, more of the drug will be there inside the tissues. That's why we call it as more tissue protein binding, less plasma protein binding. Actually, we cannot link or we cannot actually polate the plasma protein and volume of distribution bias. Even though I've explained that as a concept, not all the drug with high plasma protein binding tend to have lesser volume of distribution, and not all the drug which has got lesser plasma protein binding tend to have higher volume of distribution. Just imagine, consider we have a drug molecule which is very much lesser plasma protein binding, which means what? According to this logic, that drug should be having a more volume of distribution. But unfortunately, that will not happen if the drug is a larger molecule. If the drug is a bigger size, or if the drug is a water soluble metabolite, it cannot even cross the membrane, then how can we call that as a drug with high volume of distribution? Understand? That's why we cannot actually directly relate volume distribution with plasma protein binding. We can just think about where the drug is actually situated. If the drug, whenever you administer, most of the drug is situated inside the plasma, or most of the drug is situated inside the tissues. Based on that, we can classify both of these agents. Next one, guys. Most important question. What are the different factors which might affect the volume of distribution? Please note, volume of distribution is directly proportional to age. More the age, more will be the volume of distribution. Directly proportional to obesity. Directly proportional to lipid solubility of drug. Obesity, lipid solubility of drug, directly proportional to pregnancy. So higher the age of the patient, more will be the volume of distribution. If the patient is more obese, because more tissues where which the drug can get stored up, so the tissue protein binding is going to be higher. Lipid solubility of drug. If the drug is highly lipid soluble, that drug is going to be penetrable in nature. So more of the drug will be penetrating the barriers, producing its own responses. Pregnancy is not about the number of pregnancy, right? It's not about first pregnancy and 10th pregnancy, you know. This is about pregnancy trimester. I'm talking about trimester. First trimester, second or third trimester. As we can see, during third trimester, because of hemodynamic changes, the blood volume will be changed. And also during third trimester, we have an additional compartment, which is amniotic fluid. So volume distribution means drug is getting distributed to different fluids. Drug might get distributed to the amniotic fluid, and that's why the volume distribution also is going to be higher in those cases. These are the classical features of a drug with high PPB and a drug with a high volume of distribution. Okay, sir. What is the clinical implication of knowing about this PPB or high volume of distribution? Understand this. Be it a drug with a high plasma protein binding, or be it a drug with a high volume of distribution, a drug with high PPB or a drug with high volume of distribution, and if the drug lands up in overdose of that particular drug, I cannot do hemodialysis. Hemodialysis is going to be ineffective in those cases. And why is that? It's a simple logic. With dialysis, remember, we will be removing free drug concentration from the blood. Okay. If a drug is highly plasma protein bound, which means what? I cannot be able to remove those drugs. Only those free drugs will be removed. Of course, equilibrium is getting mismatched, plasma protein bond form will be converted to free form, and that free form in turn is going to be excreted. That's why for acute overdose, I cannot use hemodialysis. Similarly, for a drug with a high volume of distribution, more of the drug will be there in the tissues. What do we do with the dialysis? We remove the drug, free form of drug which is there inside the blood. So how do we remove those drugs which is there inside the tissues, which is practically impossible? That's why I cannot do hemodialysis. For example, I'll say a drug with high volume of distribution, example, we have digoxin. Digoxin is a drug which has got high volume of distribution. If a patient lands up in overdose of digoxin, I cannot do dialysis. And on the other hand, high plasma protein binding, a classical example we have warfarin, guys. So warfarin is a drug which has got high plasma protein binding, which means if a patient is landing up in warfarin overdose, I cannot do hemodialysis. Because I cannot do dialysis, I have created a specific antidote for these drugs. For digoxin, what is the specific antidote? Digibind. I hope most of you would be knowing it. Digibind is the specific antidote. For warfarin, we have a specific antidote which is vitamin K1. Usually you will be reading it in an inverse phenomena. I have designed a specific antidote, so there is no need for dialysis. You should read it in the other way. You have to know that for any drug, the treatment of choice is going to be dialysis. For some drugs, because of some conditions, I cannot do dialysis. For example, like digoxin or with warfarin, because these drugs are having a high volume of distribution and high plasma protein binding. In those cases, I cannot do dialysis. So what I do, I choose to opt for a specific antidote. I'll give you one more example, my dears. We have a drug called as lithium. Yes, lithium, the anti-maniac drug. This drug is having a least plasma protein binding. This drug will be having least plasma protein binding, which means can I use dialysis or not? Yes, I can use dialysis. That's why I have not designed any specific antidote for lithium. I have not designed any specific antidote for lithium because dialysis is there. So why should I, what's the need for developing a specific antidote? Okay. Now we'll look into what are all the drugs for which we can do dialysis in terms of overdose. If a patient lands up in overdose, what are all the drugs for which we can do dialysis? We have a mnemonic for that. Displacement is the mnemonic. Displacement is the mnemonic. B stands for barbiturates. Barbiturates, the sedative hypnotics. L stands for lithium. We have just now read about it. I stands for isoniazid. What is isoniazid, my dears? The anti-tubercular drug. If a patient lands up in overdose, I can do dialysis. S stands for salicylates. We'll discuss that more because just before a few minutes, I told that aspirin is a drug which has got a high plasma protein binding. Now I'm saying that salicylates, which is actually the group name of aspirin, I can do dialysis. How that is possible? We'll discuss that more under those NSAIDs. Under aspirin, we have discussed that in detail. T stands for theophylline, the drug which is used for bronchial asthma. M is for methanol, ethylene glycol. Methanol and ethylene glycol. We know that for both of these drugs, dialysis would be the treatment. D stands for divalproex. Even though it is a brand name, guys, it's a combination of valproic acid, and valproate sodium. A combination of valproic acid and valproate sodium in a ratio of 1:1 ratio. That's what divalproex is. For the mnemonic purposes, we have called it as Displacement. D is for divalproex. So for all of these drugs, we can use dialysis. Out of this, for some drugs, even though we can do dialysis, we have designed certain specific antidotes. For example, isoniazid is there, the anti-tubercular drug. Even though we can do dialysis, we have a specific antidote which is vitamin B6. Vitamin B6 given via intravenous route. Most of you would be knowing about the relationship between vitamin B6 and isoniazid. Isoniazid might produce peripheral neuropathy. For prevention of it, we administer vitamin B6, and for treatment of it, we administer the same vitamin B6 at different doses. But here we're not talking about that, we're talking about toxicity, overdose of isoniazid. In those conditions, I have to administer intravenous vitamin B6. Apart from that, we have this methanol and ethylene glycol. Even though we can do dialysis, we have designed a specific antidote, which is fomepizole. Fomepizole. How do we remember that? Simple concepts. For methanol poisoning, that's what fomepizole is. It is used for methanol poisoning, fomepizole. Apart from that, we have this divalproex, or valproic acid and valproate sodium. Patients might land up in hyperammonemia. For which can be treated with levocarnitin. L-carnitin can be used in this treatment. So for some drugs, even though we can use dialysis, we have designed certain specific antidotes. We have discussed about all of these points, guys. Understood? So a small one-liner recap. High plasma protein binding has got three major factors: more drug interaction, more duration of action, less distribution. High volume of distribution has got two important factors: more tissue protein binding and less plasma protein binding. A drug with high PPB or high volume of distribution, I cannot do dialysis. Example, warfarin antitoxin. Whereas the drug for which we can do dialysis is Displacement. Even though we have dialysis, we have designed certain specific antidotes for that also. We have to add one more newer drug body, one more D to be added here, and that is dabigatran. One more D over here is dabigatran. What is dabigatran? As the name itself implies, TRAN, it is a thrombin antagonist agent. This dabigatran is an anticoagulant. I can do dialysis, and we have designed a specific antidote for it. The specific antidote is called as idarucizumab. Which is a monoclonal antibody, a specific antidote against dabigatran. We have a certain ways of remembering these monoclonal antibodies. We have discussed that more under pharmacodynamics, guys, right? How monoclonal antibodies nomenclature is actually there. We have discussed that there. Please take a look at it. Okay, with this, we complete about the classical features of drug with high Vd or high plasma protein binding and drugs for which we can do dialysis. We'll move to the next one, guys. Let's talk about redistribution. So what is redistribution? We have discussed about one important point previously, which is about distribution, movement of drug molecules from the blood to the tissues or organs or to the tissues. Redistribution means whenever you administer a drug with a high lipid soluble capacity, consider you administer the drug, this drug gains entry into the blood. We all know that. Now what happens, this drug is going to be accumulated more inside the blood. For example, you administer 100 milligram will be there in the blood. Now this drug is having a high lipid solubility. It have to penetrate majority of the barriers. From the blood, it will penetrate, gain entry into the brain, and it maintains an equilibrium, which means what? 50 milligram will be there in the blood and 50 milligram will be there in the brain. Equilibrium is attained. But unfortunately, because this drug is having a high lipid soluble capacity, those 50 milligram which is there in the blood cannot be remaining more inside the blood because the equilibrium is attained between the blood and the brain. Now what happens, this drug which is there in the blood will move on to the next tissue. For example, we have skeletal muscles. Because it is having a very high volume of distribution and drug with a high lipid soluble capacity, this drug, because it cannot move more, it cannot break the equilibrium, gain entry into the brain. What happens, these 50 milligrams will start moving towards the next tissue. Now what will happen, buddy? Because 50 milligram was there inside the blood previously, now it has been changed to 25 milligram and 25 milligram, which is accumulated there inside the skeletal muscles. Now what happens, the concentration in the blood is how much? 25 milligram, is that right? Because the 25 has moved into the skeletal muscles. So 25 was there in the blood previously. How much was accumulated inside the brain? 50 was accumulated. Equilibrium is getting mismatched. Now what will happen? Drug from the brain will start moving back inside the blood. and from the blood again it will start moving to the skeletal muscles. So simply when you look into what exactly happens inside the human body, you administer a drug with a high lipid soluble capacity, and that drug, whenever it is administered, it will immediately gain entry into the brain, and after immediate short period of time, from the brain it will come back to the blood and it will come back gain entry back into the skeletal muscles. So the effect of that drug inside the brain would be for a very much shorter duration. It will not be there for a longer duration. This concept is what we call as redistribution. This concept is explained as redistribution. Redistribution means drug is getting redistributed into the skeletal muscles. So from the blood to the brain, from the blood to the brain first, and again from the brain to the blood, and from the blood to the skeletal muscles. This sequence is what we call as redistribution. It is not seen in most of the drugs, but seen primarily in a drug called as thiopentone sodium. Thiopentone sodium, a famous question. Thiopentone sodium has got a very much shorter duration of action. And why is it having a shorter duration of action? Because of redistribution and metabolism. Because of redistribution and metabolism. So if you come across a question, which of the following, or say thiopentone sodium has got a shorter duration of action, the reason behind that is option A, redistribution, option B, metabolism, option C, both. The answer is going to be both. Is that clear? That's it about redistribution, guys. With this, we complete the most important topic in pharmacokinetics, which is distribution. Thank you.